Hi, everyone. Welcome to a very quick presentation about cardiovascular pharmacology. So if you go out into any field in PT, even outpatient, you're going to be exposed to a lot of different medications in the patient's chart. And a lot of times, the medications a patient is on won't guide your practice, especially an outpatient. You know, a patient might be taking a medication every day, and it's pretty mild and it really has no bearing on your plan of care. But in most settings, and really even in outpatient, a lot of your patients will be on multiple medications. It's often referred to as polypharmacy, 5 or more medications. And so you need to have some basic understandings of what these groups of medications do, what they're intended for, so you learn a little bit about the patient's disease state, but then what some of the consequences may be. Now, you don't need to know specific medication names. You don't need to know, this particular beta blocker versus that particular beta blocker. I just want you to know what beta blockers are. I want you to know what nitrates are, diuretics, calcium channel blockers, and that's the purpose of this short presentation. The first category of medications, or categories of medications we're going to look at, are related to ischemic heart disease pharmacological management. And this is a very common disease process. I mean, maybe the most common. I mean, all of your patients are going to be, I shouldn't say all your patients. I'm biased by the setting that I work in, but many of your patients are going to be on a medication related to this process. So we'll go ahead and start. What do anti-ischemic drugs do? Well, they're all related to this balancing act between oxygen supply and oxygen demand. If adequate oxygen supply is not being, or if adequate oxygen is not being supplied, if demand exceeds supply, the heart is operating in an ischemic state. It's in an oxygen deficit. And so there are drugs that can modulate the supply and demand teeter-totter. And just real quick before we get into them, I just want to mention rate pressure product. This is a measure of the heart's oxygen demand. The higher the rate pressure product, the higher the oxygen demand. And so what we say is any drug or activity or anything that increases heart rate or blood pressure increases the rate pressure product and therefore increases oxygen demand. So if we're trying to prevent ischemia, we're trying to decrease rate pressure product as much as safely possible and also increase oxygen supply. And that's how we divide these two categories of drugs. Drugs that decrease oxygen demand and drugs that increase supply. So we'll start with drugs that decrease oxygen demand. An incredibly common category of medications to see on a patient's chart is a beta blocker. And you won't know it's a beta blocker. You're going to see a list of medication names, and the longer you practice, the more of those you'll probably memorize. But often you'll just, punch it into Google and find out that, XYZ medication is a beta blocker. So what does that mean? It means that it blocks one of, or potentially two, different types of beta receptors. These are receptors for the hormones that your sympathetic nervous system releases, epinephrine and norepinephrine. And so these are hormones and neurohormones released into circulation that cause all sorts of different things. But if you've ever experienced a fight or flight response where you've been scared and your heart rate goes up and your blood pressure goes up and you just feel that kind of sense of terror, that is a response brought to you by epinephrine and norepinephrine. So blocking these receptors blocks that type of response, or more specifically, it blocks a lot of the things that we're trying to avoid in an ischemic event. It blocks increased heart rate and it blocks increased blood pressure. So that's good. It decreases myocardial oxygen demand by decreasing heart rate, by decreasing blood pressure, by lowering your rate pressure product. Now, these can be further broken down into B1 selective or cardioselective or non-selective. So the kind of unfortunate thing for the early pioneers of beta blockers was that, you have a lot of beta 1 receptors in your heart and beta 2, but your lung has beta 2 receptors. And so what happens is if you block the beta 1 receptors in the heart, you have a tendency to also block the beta receptors in the lungs, which could cause bronchospasm. It would cause vasoconstriction. And so that's because in the lungs, the sympathetic nervous system dilates the airways. And so what would happen is, yes, you're decreasing myocardial oxygen demand, but you're also decreasing the ability to get oxygen in your blood. So beta blockers that were non-selective wouldn't necessarily have a positive effect. And they could cause all sorts of lung issues, especially if you had asthma. So cardioselective beta blockers affect the heart only. They affect beta 1 receptors only. And so that's obviously preferred in the management of ischemic heart disease. Calcium channel blockers, if you were able to take my undergrad class and we talked about muscle physiology, we would learn that calcium causes muscle contraction. It's a somewhat complicated process, but if calcium is released inside of a muscle cell, cross-bridge cycling occurs, muscle contraction occurs. So if we block calcium channels, we blunt contraction. And so that's why they're here under the drugs that decrease myocardial oxygen demand, because they blunt contraction. But most of their effect is actually due to smooth muscle dilation of veins and arteries. So we also put this category under drugs that increase supply as well. So we'll talk about them in both places. And then along the same line, nitrates is a powerful coronary vessel dilator. So if there's some sort of occlusion, nitrates cause dilation, which increases supply, but also they blunt contractility and slow down heart rate. So they're under decreased demand as well. Okay, so what increases supply? Well, if there's already a clot of some kind formed that is blocking blood flow, a thrombolytic will be administered. This actually destroys the clot. It lyses it. So that's a thrombolytic. An antiplatelet prevents platelet aggregation. So this stops formation of additional clots. This is also true for anticoagulants. This inhibits the ability of a fibrin mesh to form, which causes red blood cell aggregation and clot formation. And then we have calcium channel blockers, which are vasodilators that increase oxygen delivery in the heart. So the first three are really about destroying or preventing clots, and then calcium channel blocker is a direct method of increasing oxygen supply, irregardless of the clot formation. That takes us to heart failure. These are, it's hard to say which is more common, but you're going to see these on just about all of your patients in the hospital or in the skilled nursing facility or in home health. And this is especially true for this first one, diuretics. So I suspect you guys probably know diuretics cause increased urination. You are decreasing the fluid volume in the body, and that decreases the afterload, which takes a lot of the workload off of the heart. And so this is, maybe the most common type of diuretic. It's a loop diuretic. I'll explain what that means. Called Lasix, or furosemide is the actual name you'd be putting in the chart typically. And it increases urination and decreases blood volume. Beta blockers lower blood pressure, as we already discussed, by blocking beta agonists, and also by kind of blunting contractility of the heart, which also decreases blood pressure. ACE inhibitors act on a very complex system called the renin-angiotensin-aldosterone system. ACE stands for angiotensin converting enzyme, and it converts angiotensin 1 to angiotensin 2. That's what ACE does in the lungs. It converts that compound. Angiotensin 2 is a powerful vasoconstrictor, and it increases fluid retention. So an ACE inhibitor blocks that. So it causes vasodilation, and it helps stop fluid retention, which is a problem in heart failure. If you have heart failure, you have decreased perfusion in the kidneys, so your body thinks it needs to retain water. So an ACE inhibitor helps tell your kidneys to cut it out, basically. Stop retaining water, let that water go, and then that will help the heart to function more normally. Vasodilators, same thing. It's going to lower blood pressure, which means lower afterload. And then a positive inotrope. So a positive inotrope is something that increases contractility of the heart. A really common one is digoxin. It slows down heart rate, but increases contractile force. And that's good because in heart failure, the heart's really struggling. It's pumping as hard as it can and as fast as it can, but it's doing so ineffectively. So a positive inotrope helps it do it more effectively at a slower rate, which is better for the heart in that situation. So digoxin is a common one. Hypertension management has gotten incredibly complex. There's all different sorts of combinations. Diuretic management is the most common, especially loop diuretics. These are diuretics that function at the loop of Henle, like Lasix. These are the most powerful type of diuretic, but there's other kinds that function in different places, so you can combine diuretics sometimes, or a diuretic and an ACE inhibitor, or angiotensin receptor blocker, which kind of has the same effect as an ACE inhibitor. So lots of different combinations, all of the above can be used to treat hypertension. And you start to notice, this last slide, this was for heart failure, but it's essentially the same group of medications for hypertension. And that's because often we're sort of treating the same process. The hypertension is feeding into the heart failure. So there's, of course, differences, and this is super complicated. I'm oversimplifying it for our purposes, but I just want you to kind of have some basics. And so, yeah, I know that was super short. I'm sure you're not really applauding like this photo, but it is nice that it was quick. I just want you to know the categories. So, if you have a question on a quiz about, what is the basic effect of a beta blocker? Well, it blocks beta receptors, so it blocks the effects of epinephrine and norepinephrine, which lowers blood pressure, slows heart rate, slows down contraction force. And really what I want you to know is it decreases myocardial oxygen demand. So for each of these medications we talked about, I just want you to know the basic effect of that medication. Thanks.